have a technique where they can inject a tracer that goes through the vein, gets into the brain, and if there is amyloid plaque deposited there, then remember that's a hallmark of Alzheimer's disease, this tracer will bind to that amyloid plaque, and then a PET scan, a special type of scan, will be able to detect the retention of this tracer because of amyloid plaques. This would be a PET scan of someone who has lots of amyloid in their brain. So if this holds up, and other biomarkers like it, we may be on the verge of having a test to show us Alzheimer's disease in a living patient before they have to come to autopsy when we look at the brain under the microscope. Now I show this, we've been studying lots of people at Washington University who are very healthy from age 45 to age 88 with this amyloid tracer called PIB, and this just shows the amount of amyloid tracer retention, binding there is in the brain. You can notice that almost everybody has little or no amyloid tracer retention, that doesn't have amyloid in the brain, even our oldest person. But some people, beginning around 55, have an increasing amount of retention. Here's the actual percentages of this. So a few people from age 50 to 59 have amyloid in the brain, about 6%. A few more, about 18% from 60 to 69, from 70 to 79. Now it gets to be a little more substantial, 26%, and 30% of our series in this case of 80 to 89-year-olds. Now remember, all these people are perfectly healthy. They don't have any symptoms of dementia. But the question is, if they're carrying this amyloid in the brain and they continue to live, does this mean that they're destined to become demented? If so, this might be a stage where we can intervene and try to prevent the dementia from occurring if we develop those effective therapies. And I'll just show you one last imaging sign of a group headed by Brad Dickerson at Massachusetts General Hospital has shown that in those people who have the amyloid in the brain, even if they're healthy, they're already beginning to experience brain changes. They're losing, shown in the red and yellow areas, they're losing the thickness of the brain in these areas, and then once they develop dementia and progress in dementia severity, it gets more pronounced. So I think this group of individuals are non-demented individuals, no dementia, but already having the amyloid plaques in the brain as depicted by this PET scan indicate they're beginning to lose brain structure. So this is not a benign process. So what I hope is that in 2020, at the, let's see if my calculations are right, the 40th T.S. Srinivasan lecture, that you'll have someone here who can say that we have developed a way to detect Alzheimer's changes in the brain, regardless of whether the person is demented or not, and that we will have now some therapies to be able to treat them. So what I hope I've been able to share with you today is that all countries are experiencing an aging population, and Alzheimer's disease, as a very clearly age-related illness, will soon reach epidemic proportions, not just in the United States, but worldwide, everywhere, India included. We need improved detection, and I think detection at a stage before there is substantial brain damage. I think we're very close to being able to say that we can do that. And finally, if we can detect the illness at a very early stage, we need to do something about it. We need to have drugs that interfere with the abnormal process and arrest the ongoing brain cell destruction. If that's the case, then I ultimately hope that not only will we be trying to cure people who have the Alzheimer dementia, I think our greatest chance of success will be trying to prevent people from becoming demented. Thank you very much for your attention.
One of the outcomes of this oration was the suggestion by the family that it should not end like a movie, but there should be questions and answers. So now I would call upon the audience to participate with the expert, and Dr. E.S. Krishnamurthy will help him. But what I want to say is that what he said just now about the aging population, what Jean-Marie Charcot said 100 years ago in France was, disease is of old, nothing about it is new. It is we who learn to recognize what was formerly imperceptible. So when we were saying that people are aging, we didn't consider dementia as an illness, but now we know that minimal cognitive impairment, that's one new definition that has come. But the worry that people have in India, at least in the south, is when they can't remember things. So George Burns said, first I forget the faces, then I forget the names, and God knows what I forget next. So I would request the audience to participate. Yes. Dr. Nair? Yes. He's a pharmacologist. There's a mic there.
My name is M.G. Nair. I'm a consultant to pharmaceutical industry, particularly in R&D. I have two questions, if I may. Number one, when you put those numbers about the US population's high incidence, is there a breakup according to the ethnic mix-up? That means Caucasians against African Americans, against American Indians.
So shall I answer question one?
Yeah,
I very much appreciate that you're not testing my memory by giving me two questions at once.
Fine.
So the first question is, in the United States, have people looked at the frequency of Alzheimer's disease across different ethnic groups? The answer is yes. In the United States, more or less, the frequency of Alzheimer's is the same across ethnic groups. However, if you look at African Americans, for example, the frequency of Alzheimer's disease in Africa is much less than in African Americans living in the United States. The same holds for Japanese Americans. The frequency of Alzheimer's disease in Japanese people who have moved to the United States is less than in Japan. So in the United States, about the same, but I do think that there are population differences, not just genetic factors, but I'm sure cultural and dietary factors play a role as well.
Yeah. The second question is, you know that in Oriental systems of medicine,
is that the question?
Yes.
Do I know the Oriental systems of medicine?
Well, you know that there are Oriental systems of medicine. Okay.
That I do know, yes.
Some of our systems are as much as 3,000 years old. Now, they have highly individualized systems where the individuals and persons are treated rather than the symptoms of the disease. Now, in that process, the fundamental principle is one of use of adaptogens, anti-aging products, antioxidant products, free radical scavengers, and so on. Do you think this has anything to do with the lower incidence as we see it today? Because 60% of the population in India still rely on these systems of medicine.
Yes. So the question had to do with the frequent use of well-developed Oriental traditional methods that include use of antioxidants and other agents, and can that be an explanation for what is the lower frequency of Alzheimer's disease in the Indian population? The short answer is yes, that is the case. I'm not sure that that's the only reason. I think that certainly is an area that needs research, but I think other factors must be evaluated as well, including psychosocial factors and dietary factors. Now, I will say that in the United States, even though we don't have that 3,000 years of tradition of medicine, we have tried to look at some of what we think are the active agents in traditional Oriental medicine. So we've looked at something called huperzine A and have not yet found a benefit for that. And just recently, a very long study, a very large study of ginkgo biloba, and that was negative as well. So we're quite open to, and I mentioned the curcumin, we're interested in looking at that. So we're quite interested in trying to explore what seems to be effective, but I'm not sure it's only the traditional methods. There may be other factors. Yes, ma'am. Two people, two ma'ams.
There are more than one or two siblings in a family where a parent has had Alzheimer. Is there any order in which, in the sense, the youngest gets it or the oldest gets it? Is there anything like that genetically?
Yeah. So thank you for that question. It has to do, if there seems to be a family tendency to have Alzheimer's disease, is it related to the birth order of the children? Would the eldest be more at risk or the youngest more at risk? That's a very interesting question. I have to answer at this point, no. There does not seem to be a clear risk depending on the birth order, but I will just mention that the older the mother at the age at which she delivers the child, the more chance that she will pass on a certain genetic profile in an organ called the mitochondria. And that has been associated potentially with Alzheimer's disease. So it's a very good question. We don't have enough finite information to address it 100%, but doesn't seem to be a great change, but we need to look at some of these factors. But right now, may I ask, are you the youngest or the eldest in your family? Yeah, then you're fine. So no. Was there another question? Yes.
Dr. Kamakshi?
For an excellent talk. Aging and Alzheimer's disease. Now, when exactly do you say that this is aging and this is Alzheimer's disease? The borderline or the hinterland between the two is extremely narrow. And is it possible to say, using one clinical factor or some clinical factors, say memory or some aspect of memory, which is going to guide us to differentiate the two, sir? This is one question. The second is, what is the exact genetic relationship between Mongolism on one hand and the development of Alzheimer's on the other?
Right, thank you very much for those questions. So the first has to do with how physicians can differentiate healthy aging from the very earliest stages of abnormal aging, which would be dementia. And you are quite right to highlight how difficult that is. That is not an easy diagnosis at all. I think I use the principle that truly healthy people are able to do the daily things that they have always done without needing other people to help them. Now, they may need to start making lists of things that they need to do or write things on a calendar to make sure they don't forget appointments. But if they're doing it themselves rather than someone saying, you need to go to the doctor, today's the day, then I think that that's normal. In early stage Alzheimer's, already that is beginning to fail, and other people are trying to help supervise them. But the change point is not clear-cut. It's very gradual. So it's quite difficult to know when you transition from healthy to abnormal. So that then, I think, gives even more impetus to trying to develop these biomarkers. So then we can tell, does the person have the brain changes that we can visualize by scans or protein analysis or something else? So I do think we need better diagnostic tools, and I'm hopeful that the kinds of biomarker research that is underway will help us with that. The second question had to do with Down syndrome. Does everyone know what Down syndrome is, pretty much? So Down syndrome is when one of a child's parents contributes 2 copies of a chromosome. It's called chromosome 21. Normally, each parent contributes only 1 copy, 1 in the sperm, 1 in the egg, and then the child gets both, so they have 2 copies. That's the normal situation. Well, in Down syndrome, one parent, usually the mother, gives 2 copies. That's abnormal. So the child ends up getting 1 from the father, having 3, okay? And that's the official name of Down syndrome, trisomy 21. 3 copies rather than 2 of chromosome 21. On chromosome 21 is the gene that produces amyloid, this protein that I say makes up the plaque. So from the time of conception, the Down syndrome child has 50% more generation of amyloid through their entire life. So by age 35 or 40, they all have amyloid plaques in the brain, 100%. So Down syndrome is a rare genetic cause of early onset Alzheimer's disease, we think through the amyloid mechanism. Sir.
For the management of decline in cognitive functions, do you think there is any scientific basis for drugs neuropharmacological manipulation to enhance one's normal cognitive behavior, particularly in the aging brain or the aged brain?
Thank you. Yes, so the question has to do, in a healthy person, are there ways that we can enhance mental abilities, cognitive abilities? If I had the answer to that, frankly, I would not be here. I would be in Tahiti or someplace like that. We do not have a clear way to consistently improve mental abilities in healthy older adults. I will tell you, however, that some of these medications that I mentioned are available now for treating Alzheimer patients have been used in select groups of individuals. For example, airplane pilots taking the drug donepezil, which is a pharmacologic enhancer of the cholinergic system, they're actually more alert, the airline pilot. So I hope my pilot tomorrow is taking that drug, but it doesn't last. It doesn't have any meaningful improvement over a period of time. So we're all of us, as we get older, are interested in trying to keep our brains working at a high level, and is there potential for development of those drugs? There is, but we don't have them yet. Sir.
I would like to ask you, since you mentioned the cognitive temporal latency, latency response, are there techniques that, there are techniques that look at neural response to millisecond resolution?
Right.
Like EEG and
right.
immediate. Are they being used in this?
Yeah, so the question has to do, I mentioned tests and biomarkers, and I didn't mention them all, and one of them has to do with electrophysiology and magnetophysiology, looking at how the brain processing occurs, because we can track that, we can measure that. Are there people looking at that? Absolutely. To date, I would say that they haven't come up with nearly as promising results as some of the techniques I showed here, particularly with the imaging. But people are exploring that, and I think that should go forward. Dr. Sisodia.
Yes.
Right behind you, sir.
So John, I was curious about the experiment that you showed, which showed the level of PIB imaging across the normal aging continuum. You had a number of individuals who had very high levels of PIB. Is there any correlation between that level and their conversion to Alzheimer's disease at some course over time.
Right. So Professor Sisodia has asked if you have a high level of amyloid in the brain, as demonstrated by this PET PIB scan, what happens to you over time? So I will say that the entire PIB story only has come out since 2004, and we have only begun studies at that year, and we have insufficient duration of follow-up to answer that question. However, I think that it is likely to be associated with the development of dementia, one because of the cortical thinning work that Brad Dickerson and others have done, two because of our own work. In our healthy people, those individuals who have the PET PIB scan already are declining on their cognitive performance on psychometric tests. They have not reached the level of dementia, but unlike our PIB negative people who maintain their cognitive performance, these people are declining. So I think it's a matter of the follow-up period, and but do we have the answer? We do not.
John, my question was, when you did the PIB imaging, did you see any spatial differences in the amyloid deposition across the brain? And would that correlate with cortical, with the cortical thinning? I mean, was there a correlation between amyloid deposition and the thinning?
So the question is, with this imaging technique to show amyloid, where are the high areas of amyloid deposition, and does that relate to the brain thinning? Most of the amyloid deposition seems to be in prefrontal cortex and in lateral temporal cortex. The brain thinning is in limbic areas first. That's where it occurs. But I think what we have to understand is there are associations between these areas. So the limbic cortex and the prefrontal cortex are interconnected. So we don't see much amyloid in the hippocampus or in the rhinal cortex, but I think the pathways are involved.
Any further questions? Yes.
I'm Dr. Rama Gopalan and head of the Department of Pathology. I was happy to note that you were also a pathologist and must be another pathologist as yet. I just wanted to know some of the changes that you see in amyloidos or amyloid plaques and tangles, and whatever you're mentioning as drugs seem to be like some of the anti-lipidemic drugs and antioxidants. So is it possible that some kind of an atherosclerotic process is leading to this, and an old associated with the aging, because the aging brain also seems to have the same kind of atrophy and other things going on. So are we really seeing another aspect of aging in the form of plaques and tangles, like some of this atherosclerosis in the cerebral arteries and some other endothelial dysfunction which is going on?
Yes. Yes. So the question has to do with the potential interaction of the arterial or vascular changes, atherosclerosis, and the development of Alzheimer's. Maybe atherosclerosis isn't simply a risk factor for the development later of amyloid plaques and so forth. Maybe it's actually involved in the development of the amyloid plaques. And yes, I think that's a viable hypothesis. I should tell you that some of the therapies that I mentioned that have potential are really directed, as you saw, the statins and so forth, at the vascular hypothesis. And finally, I think they certainly need to be explored. And I should have said this, but I'm glad you've given me the opportunity now to emphasize this. I think that Alzheimer's disease is too complicated an illness to be simply amyloid plaques or tau tangles or simply vascular changes. I think it's a combination of many factors. And I believe that ultimately there will not be a single drug to treat this illness. It's going to be a combination of different drugs, and I would suspect that some of them will be vascular drugs. Sir, did you have a question in the back?
Dr. Subramaniam, my question is similar to what Dr. Rama asked. Like for the healthy heart, we have the statins, the ACE inhibitors, and the aspirin. Are there any drugs in the pipeline for the aging brain which will prevent, like you said, donazepam is not of much use at this point as a preventer. Anything else in the pipeline?
Not that I'm aware, not yet. But boy, we're all interested in that, so.
I'm not a doctor, but my question relates to your turmeric curcumin. How intense is the research?
Not very.
Thank you.
The reason I mentioned dietary factors and sort of emphasize that is I think that's an area that should be emphasized, but it is not getting enough attention. And so most of the studies that have been done have been very small and not large numbers of people and not many different programs that have participated. So I think there's, as we talked about earlier, I think there are differences between populations. Some of those may be genetic difference, but some of them may be cultural, lifestyle, dietary, and I think we need to explore them much more than we have to date.
Dr. ESK, you want to say something?
Only to draw attention to the whole area of social reserve and its importance as a potential contributor in terms of keeping prevalence low in rural and traditional societies, and why that needs to be looked into also more carefully, but also to make efforts to preserve the social fabric. I think going back to basics and retaining traditional societies may be the best thing we can do for aging populations. Because a Swedish doctor once came and told me in a dementia conference after I spoke, he came and said to me that, we are building better and better places for old people to live in magnificent isolation. I hope that countries like India don't do that, and I think that that's a message for all of us as well.
So I will now propose the vote of thanks, but before I do that, I need to say two things. One is that regarding memory, most people are concerned about memory. That's the first thing they mention when they come to you because they're worried. So the O'Sullivan brothers were performing, and the younger brother was prompting the older chap from near the green room, saying what he should say. And he said, "You silly man, it's not that I don't remember the line, but who says it first?" So that's the selective memory. It is traditional in this oration that we all stand up and give a standing ovation to the Srinivasan family. And now we give another oration to the distinguished speaker. Yesterday I gave a talk at the Savita Medical College, which is a new venture near Chembrambakam Lake, and I gave the same talk I've given several times, and I said some of the qualities for the success of a doctor, the first is good health, not made in the walking gymnasiums of the country, given by God. And the second quality I said was a doctor should have good luck, and I've had the best of luck that this family has supported all our programs and brought the best people from all over the world. And it's sometimes you wonder how we started this and how it has reached such a zenith. So I think this is something we have to understand very clearly, because some of my teachers told me, go to the families and they'll help you. Because one of the privileges given to a doctor is to get to know the families, and they get to know you. I wish to also thank the staff of Sundaram Clayton, starting with the Executive Director, Mr. H. Lakshmanan, the finance people, and all the others who work with Mr. Venu Srinivasan, and in particular the Bala, whose neck I've been sitting on for the last couple of days to get things going. Most of you know that neurologists are obsessional by nature and tend to sort of repeat and go back and check many a time what's going on. And then all my staff who have worked very hard for the Delhi meeting, and I'm happy that the focus has shifted to the national level. And Vijayalakshmi Ravindranath thank you very much for your... The other thing is that we have two other distinguished people who will be representing. One is Professor Sisodia, and the other is Professor Ganguly, who's not here. She'll be meeting us in Delhi. And it is good that we have discussed this because the Census Commissioner's statistics at the time of independence, a woman in India died at the age of 28, man died at the age of 30. Now a woman dies at the age of 62, man dies at the age of 62. So I think there's an enormous change in the society in general, and what is mentioned by everybody about the aging population. And I do think personally, having grown up in a joint family, that the best way to preserve our old people, to look after them carefully, is that we try to live together, even if it means a bit of quarrel here and there. It doesn't matter. That's a very minor issue. I think we listen to that all the time. But the health is, I think, the maintenance of health. India has always played a leading role in the family. And as far as I can see in Chennai, when we look at these patients who have these problems, it is the family who ultimately have to take care. Whatever you may have from outside, it's the family member. And if you read the Oxford Book of Clinical Medicine, there is a whole page devoted to the carer and what difficulties he has to go through. And I know that I know of several carers who have spent so much time with their parents and their families. Ladies and gentlemen, thank you very much for your response to our invitation, and we look forward to meeting you next year. Thank you. I would request the family to join the traditional group photograph in front of the portrait and then proceed to high tea.
All right.